So, good afternoon, everyone. Myself, Dr. Santosh from Hyderabad. Just Dr. Krupa spoke about what are the first line options in case of upfront metastatic renal cell cancer. We have seen there are multitude of options. Nobody knows which is the right option. So, my thing is much more difficult. We have no data how to choose the second line option in case of advanced renal cell cancer. So, how do we choose in this scenario is the main topic of discussion. So first, what are the active agents in renal cell cancer? The renal cell cancer is very much dependent on angiogenesis. So angiogenesis inhibitors have proven from long, these are the most effective agents in case of renal cell cancer. We have sunitinib data from much long. We have immunotherapy data. It is showing renal cell cancer is one of the immunologically active and hot tumor compared to other cold tumors. We have data with mTOR inhibitors. We have data way back 40 years ago using high-dose interleukin-2 to completely cure renal cell cancer, where even metastatic cancer, because of its immunological hotness, interleukin-2 would be curative. But this availability of interleukin-2 is the difficult, and the complications of interleukin-2 is difficult. Nowadays, emerging option of hypoxia-inducible factor inhibitor, the standalone drug belzutifan, and of course, whenever two different classes of drugs are showing action, we use combination of the drugs. It could be combination checkpoint inhibitors or use of checkpoint inhibitors with the TKI. That was what started in the first line. So first line, prior the standard of care was single agent TKI, that has shifted now to combination of TKI with checkpoint inhibitors. So how do we choose the right second line answer? There is no single answer for this question. It depends on what agent the patient has been on the first line, because the resistant pathways of various drugs are different. As Dr. Kripa spoke about, axitinib is a narrow inhibitor of tyrosine kinase inhibitor, whereas cabozantinib is a broad spectrum inhibitor of tyrosine kinase inhibitor. Suppose there was a narrow spectrum inhibitor in case of sunitinib or sorafenib, pazopanib. Second line, we go for broad spectrum. Also, the nature of progression. It was lot seen in many clinical trials that asymptomatic progression, that is only imaging-wise oligo progression, can be managed by continuation of same therapy, and we can give locally ablative therapies. The comorbidities associated, we choose our agents both in the first line and second line based on what comorbidities the patient has. And of course, if there are any specific sites of metastasis, suppose the patient has a solitary brain metastasis with raised ICT, so our approach differs even if it is first line or second line. And what are the symptoms of at relapse? Are there any aggressive symptoms? Suppose a patient who did not undergo nephrectomy at second line has large renal hemorrhage. Even in second line setting, we may have to do nephrectomy as a part of salvage of his life. So the problem in choosing a right agent is increased use of the most active agents in renal cell cancer, that is using of immunotherapy and combination of TKI upfront, as a result of which we are getting limited agents in the second line. So this is an area of active research. If available, clinical trial is the way how to go. And we have seen the data of adjuvant immunotherapy. In future, the things would be much more complicated when a patient has received adjuvant pembrolizumab after surgery. If he relapses, how do we give the first line and second line? So even with increasing use of immunotherapy in the adjuvant setting, further it would be much more difficult. There is no randomized data to guide in this area which agent to be given in the second line. So there is high requirement of research in this perspective. The second line option depends on what the patient has received in the first line. Suppose the patient received TKI alone, which we less prefer nowadays. We switch on to the alternative class of action, that is immunotherapy. We could use nivolumab, nivo plus ipilimumab. Or if the patient, suppose, is not available for this TKI, we have the data of cabozantinib from the Meteor trial and cabozan trial, and the axitinib data from the Axis trial, which has shown benefit in the second line setting. If the patient is received TKI alone, either the first option would be giving him immunotherapy with nivolumab or nivo plus EP or alternative TKI. And we have the data with lenvatinib and everolimus also. Of course, we can use the combination of immunotherapy with the non-overlapping TKI in the first. So this prior TKI, which was the predominant population previously, now with more use of the immunotherapy in the first line, this patient population we are less seeing now. Now, the second group of patients is only single agent immunotherapy if they have received. So suppose the patient had cardiovascular issues where giving of TKIs is a problem which have cardiovascular side effects. In that scenario, there is a trial called Titan RCC trial, which evaluated an interesting hypothesis. Suppose a patient on nivolumab has progression. What if I add ipilimumab for briefly 4 to 5 cycles and later continue on nivolumab? So this is act as an immunological boost for the progressing disease. They have shown that adding ipilimumab on progression on single agent nivolumab, then the patient can be salvaged and his PFS and the OS could be further improved. An interesting entity in the working of immunotherapy has came from the RCC trial. That is nivolumab study of Checkmate 025, which has shown that this was the first clinical trial in a randomized manner has shown asymptomatic progression in case of immunotherapy. They improve the overall survival also. That is a patient of nivolumab having only radiological progression without major significant clinical symptomatic worsening, where we can continue single agent nivolumab. It gives very good progress. Also, there is always a problem of immunological effect, that is pseudo progression. Sometimes using the RECIST criteria sometimes is difficult. So always taking into the radiological picture and clinical picture helps in sorting out this selection. If the patient is on prior checkpoint inhibitor only, the options for me is if there is only oligoprogression, asymptomatic progression, continuing on nivolumab or adding ipilimumab would be the right option. If the patient has not received any TKI, either cabozantinib and axitinib is an option. This is the most difficult population to treat. That those patients, the RCC has progressed after using the most active agents in them. That is, they have received already the immunotherapy and TKI. These patients we would be seeing more frequently in the coming years because universal adoption of immunotherapy plus TKI upfront would increase this highly resistant kind of relapsed RCCs. So they are already exposed to the most active agents. We have to use alternative agents. Suppose if the patient have received pembrolizumab plus axitinib or pembrolizumab plus lenvatinib, we have to give single agent cabozantinib in present. If the patient has received in the fashion of 9ER, that is nivo plus cambo, we have to use mTOR inhibitor, that is everolimus plus lenvatinib. The cabozantinib is because it's a broad spectrum, it inhibits FGFR and MET AXL also. Also, in this population who has received immunotherapy plus TKI, as I have told prior, utilization of ipilimumab, that is immune boost, is also an option. So there are few special scenarios in second line. As I already told you, if there is oligoprogression, ablate the tumor and also proceed with the primary thing. Asymptomatic progression, yes, there is a data showing that you can continue nivolumab even beyond RECIST progression. And always it is important. Even there is clinical data, strong data to show that a patient of RCC can be observed without treatment also. Because in some scenarios where in favorable IMDC group, low burden of disease, if in case of comorbidities, we can serially follow the imaging. And the role of metastasectomy in case of symptomatic metastasis or solitary or oligo is always there. Always, these are the important things we have to think before starting an agent or giving an agent in those patients who are already resistant to dual highly active agents, that is immunotherapy and TKI. So now, because we do not have a proper molecule, there are newer avenues of clinical trials, one of which is a promising molecule of belzutifan. It has shown very effective data in case of von Hippel-Lindau disease, which heavily relies on hypoxia-inducible factor. In this highly resistant population, it has shown an overall response rate of 25% and disease control rate of 80%. And combination of this new agent with non-exposed prior agent, that is using of an mTOR inhibitor with HIF alpha inhibitor, that is belzutifan plus everolimus. And another TKI, tivozanib, is also there. And baxdrostat is a newer monoclonal antibody that is against the tyrosine kinase blocker, and anti-IL-27 and girentuximab. It's like a conjugate, immunological conjugate that we use like TDM1 and trastuzumab deruxtecan. It combines uniquely the lutetium-based radioactive principle against the carbonic anhydrase. Renal cell cancer cells express very highly carbonic anhydrase. So the antibody goes and attacks the carbonic anhydrase and killed by the lutetium-based killing that we use in PSMA therapies and all. And there is an OXA40 antibody. It's like a programmed death receptor. This is one of the mechanism or the signaling by which the immunotherapy works. This is a newer immunological domain. So to conclude, we have to search for the alternative agents that the patient has not exposed, and also the treatment beyond progression should be considered when there is slow progression of disease, asymptomatic patient, and oligoprogression. We have to incorporate the locally ablative procedures. If available, clinical trial is the go to this second line setting, and more utilization of belzutifan in this heavily treated second line patients is the option. With this, I say thank you. Thank you for your patience in here. If any doubts, I'm available.
Thank you, Dr. Santosh. Just wanted to add, you have done very nice presentation. Those patients who have already received TKI and IO, in the second line, people have used IO combination like Nivo-IP, but the results are very dismal. I mean, the response rates are in single digit, 6%.
Yes.
So very few will respond to that. And what you rightly said, we have to see for other alternatives and different group of drugs. Probably that is what is going to have a major effect once patients start getting first line IO plus TKI combination.
Thank you very much. If there are no doubts, I'll take it.
Okay. Thank you, Dr. Santosh.